Good morning, everybody. Again, this is me, K1. I will be moderating this session. Me and my colleague, Dr. Rod Jalil, I forgot. Never mind. He's a urologist working in UAE. Mubada, I think. Yeah, that's right. Now, before I start moderator, my role as chairman of scientific committee, I have little notes. As I mentioned yesterday, please we have to stick to the 15 minutes, 12 minutes to the speaker, and 3 minutes to the moderator. There is a very important point. I think, please, kindly, I ask you to stay till the end of the session. We have a highly distinguished speaker yesterday. The last session, there were very few people in the lecture room. I kindly ask you, please, to stay with us and enjoy up to the last presentation. Thank you for this, and we have to start on time because our time is very limited. I will start introducing our first speaker, Professor Talal Dardari. He's a consultant and professor of pediatrics, Arab Board in Pediatrics, President of Pediatricians Across Continents Education Academy. He's a professor at the College of Medicine, University of Dubai. His presentation will be on the art of effective communication, evidence-based technique for better outcome. Professor Talal.
Well, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank Dr. Maryam and the organizing committee chaired by Dr. Manaf and scientific committee chaired by Dr. Yahya. Also the people who are working behind the scenes, Mr. Ihab, Ms. Noor, Ms. Sali, Mr. Shihab, and the other team for their kind hospitality. My presentation, please. So, this is a 3-hour workshop. I will try to squeeze it. I have been there many times and have stopped many people from talking. So I think I am going to experience to face the same experience. I have stopped many colleagues from talking. While waiting this, actually, as far as this is a general conference, I'm a pediatrician, and you may see in my presentation, you will see always I am talking about caregivers. So we are always biased with our profession, but I'm going to try to make something which is for all medical professionals regarding how we can be professional leaderships and how we can use our emotional skills, and I will go through the presentation before it is ready. So I have nothing to disclose actually. As an overview, because we are as healthcare professionals, we are incubators. So we need to care about our emotion and our emotional intelligence, as at the same time we need to care about the emotions and emotional intelligence. Please don't count this time on me because it is not there. Okay, so this was another overview, and so we need to practice all these things. And before I go ahead, people are looking to us, to our behaviors, not only to what we say. So I will do some simple practice, and I will see how it affects you. The cues of believability are either vocal or verbal or visual. So I want each one in the hall catch the fingers like this. Please, can you do it like this? And put it on your chin. Please, put your fingers on your chin. And actually this is cheek and not chin. Everyone is putting his hand on his chin. So I was asking you, all of you know English, and I think all of you put your fingers on your cheek and not chin. Because I was putting my finger on my cheek, so you just did what I was doing, although I was saying something else. So people look to us. Anyway, this is an introduction how the leadership can affect us. This is and how we'll use the social intelligence for that. And we are going to talk about empathy and understanding that. I already talked something about the overview. We passed this. So to be compassionate leader, we need to be understanding. So we understand what the people are struggling with and what are their conflict, and also empathizing. It means to put yourself in the shoes of the others and understand their feeling and their emotion, and also to be attending and listening with fascination to people while we are talking to them, and at the same time helping others, giving them thoughtful solution for their problem what they are facing. So if you are attending and helping, empathizing and understanding, you will be a compassionate leader for your team. This is the iceberg theory, and I'm sure all of you go through this. I'm sorry, I should be fast to fix to the time. So what people sees are helping, attending, empathizing and understanding. But what the other skills we need, and we are applying them actually in our daily practice, is the self-awareness, the social skills, active listening, self-regulation, express feeling, relationship management, and also understanding others. So in the past, we were expecting that people who are more intelligent, they will be more successful. So we were expecting that people with high IQ would be more successful than those with less intelligence. But what about book smarters versus street smarters? Now we realize that people with not very high IQ, but who adapt to the situation, they be more successful. And because of that, many of our colleagues who were in the first in the rank at the university, كنا نسميهم السشاشين زين they are now below the list, while others, I myself, I was not one of the sashashin, alhamdulillah, so I was at the end of the list when I finished. So the street smarter are now more successful in life than the book smarters, and this is very important actually as a professional. Sorry, I didn't mention what Charles Darwin said. He said that it is not the strongest of the species that survive, nor the most intelligent, but the ones most responsive to the changes, who adapt the changes and who know the changes. So now we are talking about EQ and IQ. So emotional quotient and intelligent quotient, and those are two different entities. The IQ, it means that something you inherited from your parents, and you know the reasoning, and you know what is happening. And this is controlled by the neocortex or the cerebral cortex. While the EQ, it means the emotional intelligence. It includes not only limited to our empathy, to our socializing, to our self-awareness, to our self-control, to our emotion, and to other stuff. And actually, this is controlled by the lower parts of the brain, middle part of the, and especially limbic system, and very specifically by the amygdala. And those can be developed actually. So if Daniel Goleman and Darwin to be believed, it is emotionally intelligent individuals who are most able to adapt the dynamic environment, and therefore the most likely to survive and succeed in life. Sorry. So this is just comparison between them. So people who are appealing to the emotion to convince have EQ, while the EQ, they use only facts, and those who are using their cognitives and emotions with high IQ, and the others with IQ, they only use logics and others. So the people with EQ, they know how and why, but the people with high IQ, they know only what, and also they treat patients with high emotional intelligence. They treat people in different way. Each one needs to be treated in the same, in different way. While the people with high IQ, they treat all the patients people in the same way. And also, we can develop our emotional skills, but our IQ is fixed, and we inherit it from our parents. So about emotional intelligence, this is very important. How can we be compassionate leader leading this? So we connect our brain to our hearts to deal with the others and to work in the medical field as healthcare professionals. So there are a lot of things. I think I go through some of this through my presentation, but as physicians, we need to be very aware of our emotion and our other emotion, and we should use all our emotional skills in our field. And Goldman, I am always referring to him because I am maybe biased by some of his talks, but I really like him. I go through many of his books. So he includes emotional intelligence in the social self-awareness. First of all, you need to be aware about emotions. By the way, there is something. It's called a critical window. It is the window between our emotions and our feeling of our emotions. So the most challenging emotions are fear, anger, and sorrow. Some people, they have this period is long. So they take long time to understand they are angry. While others, they have a very short one. So immediately they realize that they are angry, or they are sad, or they are fearful. So they manage their emotions before they make a decision, and I will go to that. And also about self-regulations, and also social awareness, and which is called also situational awareness, and also relationship management. We will come to them one by one. This is also, we need to know about emotional status and the other details. About the self-awareness, it means that, what we mean by self-awareness, that you can deal with your emotions, while the social awareness is to know the emotions and behaviors of others, and this is called the understanding other and their feeling. This is the social or situational awareness, sorry. So, what Goldman said about this is that you know your emotions, first of all, and you manage your own emotions, you work on yourself, you practice those things with yourself so you can control them, and also you motivate yourself as a medical professional, and also recognizes the understanding and practicing empathy. There is a big difference between being empathic and sympathetic. And medical professionals, we need to be empathic, so we understand the feeling of others, but we should not be overwhelmed with our emotion and be very sympathetic, and this may lead us to make some wrong decision and as leaders. And also, we need to manage the relationships and managing the emotions of the others, and how we can help them to control their emotions. So rapidly going through the self-awareness, self-management, social awareness, and relationship management. What Tasha said, she said that 95% of people...
Doctor, 3 minutes.
Okay, thank you. She said that 95% they think that people, they are aware of their emotions, while only actually 10 to 15% of them do that. And if you deal with someone who is not aware about his emotion, it can cut the team performance into a half. And how you do this is by 360-degree feedback. It means you need to take a feedback from your bosses, from your managers, from your colleagues, from your patients, and from your fellows. So you will have 360 degrees of feedback, and this you can always go through them, and you go back and read about your emotions. And also, about self-management, we need to transit from reaction to responses. So reactions are the immediate response to a problem, while response, it means you need to pause, then keep calm, keep quiet, and even you may need to walk out of your room. Make a call, talk to a colleague before giving decision. This is very important. So if you do this, then you are practicing response and not practicing remission. I will go rapidly through this. The social awareness, Goldman, I think and the relationship management is very important. So we need to think about the conflicts. And this is very important. We don't need to hide them. So if any unaddressed conflict can take 8 hours of the team's time, and I am going to go fast through this, I think I have very empathy. I think we will go to it as a physician, we need to that. So very important about empathy. We need to put ourselves in their shoes. We need to understand their point of view, but this not necessarily means that we agree with them. So it is not always agree. You put yourself in their shoes, you know their emotions, but maybe you don't agree with their point of view. Many people, they work with this, especially leaders, with suspicion. They think they may use this to take their decisions. And now they realize that, no, wrong. We need to be empathic with our fellows, with our co-workers, with our team, but, and this will not affect this. On the opposite side, it will give better outcome. This is the SPACE formula, which we call situational awareness or social awareness, presence, authenticity, clarity, and I am going to conclude with the very last slide. So tip to practice empathy is that we use reassuring tone of voice when we are talking to caregiver or patients, so they believe us. We need to do head nodding while we are talking to them. We do some verbal, yes, yes, yeah, naam, naam. So they understand you. And we use some vocalizations. We use pause sometimes to allow them to talk. We ask open-ended questions, not closed questions. We acknowledge.
حبيبي دكتور ألف شكر تسمح لي.
I'm finishing. Thank you very much. And this is, by the way, our conference will be next month in Doha. You are very welcome. Those are my emails.
شكرا سوري بس. شكرا كاكا. الكاكا عصب هذا. شكرا عزيزي.
Ladies and gentlemen, our first presenter for this session is Professor Dr. Iyad Ismail. He's a consultant in maxillofacial surgeon. He's a fellow of the Royal College of Dental Surgery of Glasgow, Masters of Dental Radiology, and Diploma and Certificate in Oral Implantology. He's currently working in Da Vinci Dental Clinic. His presentation will be the utilization of facial osteotomies in challenging cases. The floor is yours, Doctor. Please present.
Good morning. Assalamu alaikum wa rahmatullah. I would like to apologize about my voice because I have just recovered from a flu, which is a nasty flu. Maxillofacial surgery, really, it's a wide branch, but it's very, very specific to what I'm going to talk today. It's only going to be about the osteotomies that are used in challenging cases. Where's the first slide? No slides.
Double click على الجرين. Yeah.
Yeah. As you can see, that the area is too complicated. It's a very limited area, but it's too complicated of so many structures, whether in soft tissues or in the bones. Osteotomy in general, we know that it's very easy, to cut a long bone, but it's not easy to obtain osteotomy on so complicated articulation of so many bones. As you know, the face has got 22 articulating bones on each other. So in osteotomy, we are really having the classification of Lefford, just to remind you about, that Rene Lefford, who applied these areas or these lines of fractures. Those lines are not very applicable now with the traumas, because the trauma etiology now it's very much changed. That was in the early 90s. Sorry. This is Lefort 1, that's the maxilla. This is what's called Lefort 2, the pyramid. And this is the Lefort 3, which has involving multiple bones in addition to nasal bones and vomers and all these things. The treatment which is applied in osteotomies are either to manage or to repair a developmental and acquired facial deformities, just like the craniostosis cases, like Apert and Cruzen diseases, or, as you know, those cases, you can see that there are a lot of deformities here. This patient used to have got his eyes always falling out. That's because of what's called now, I cannot call it exophthalmos, because this is exorbitism. What exorbitism means? It means that the size of the size of the orbit is smaller than the content. And that's why we don't have any lid competent. The lids are not competent. And of course, the patients are subjected to multiple diseases of the conjunctiva and ocular diseases. So this is one of the challenging cases that we have done during the sanction in Iraq, and where it is used either in combination with the cranial surgeons or as a solo cases. Then after doing the osteotomies, either we are going to do what's can we see here is osteosynthesis by just fixations, or what we can see here nowadays, we do the osteotomy and put the distraction. And the distraction now is giving a very, very much, very much results better than that one. As you can see here, there we need to put some bone graft, while here we don't need, it's just to do the osteotomy cuts, and then we put the distractor, and with the time, we are going to earn bone from that distraction osteosynthesis. Cases which are developmental, you can see that the same problem with the lack of lid, in addition to the facial deformity that the patient was complaining of, with what's called a hollow face. And after doing, this is a cut between Lefort 1 and a Lefort 3, and then bone graft. We could manage to bring the face forward and with the iliac crest bone graft. And as you can see that there is no mustache here, because the mustache used to grow inside his nose, while here he's happy about his mustache. Or cases like this with a very, very ugly profile, that you can see, this is the patient at rest position, and that's where she is smiling. We had to cut a lot of bone from her maxilla, and with the ramus sagittal splitting, we could have put the maxilla upwards, and of course you can see the profile, and now she can close her mouth nicely, while here she cannot close the lips, lack of lip seal. And this is of course one of the challenging cases where you are displacing the maxilla upwards. Osteotomies in general could be utilized to go to access what could not be done before, and of course the access in areas where it's completely encrypted in a box, and these cases, especially here, I mean, this is the base of the central base of the skull, right? And we have to displace everything from there in order to expose this area. There are so many diseases which comes here, and it's mandatory that we remove everything, otherwise the recurrence is very, very common. These are the osteotomies which are normally used to reach the center of the face, the center of the skull. A left ortho osteotomy, and as you can see that the vision is in a very, almost indirect. Or when you do this, this is very morbid, and still you have the center of the base of the skull is still not been exposed well. I have used the LEFOR2 osteotomy, okay, which is, of course, I didn't invent it, but from my looking at the LEFOR2 osteotomy to expose that area at the back. You can see I'm sorry about this, but there is a tumor here, okay, and there. You can see a big tumor here, right? Tumors which are very, very important to be removed completely, otherwise the recurrence is inevitable. So that's why the LEFOR2 osteotomy was very useful and very enough to remove. As you can see, this is a LEFOR2. We have displaced the whole face downwards, and we could have managed to remove the tumor. And this case was, of course, in combination with the cranial surgeons. And I'm sorry about these sutures. This is during the sanction, where we didn't have good sutures for the face, but still the area is very acceptable. Another osteotomy is for the mandible to expose areas which are around the parapharynx, and even we can expose the upper cervical spine, where it can help the surgeon, especially the neurosurgeon, to do whatever it is. The access to the region. This is the surgical difficulty, anatomical relation and morbidity, and as you know, there are a lot of structures which are vital. And of course, we have the complete salvage, which is very, very, very important to prevent or to avoid any recurrence. This is an example of removal of a tumor from the deep lobe of the parotid gland. You can see if the traditional way is to remove the whole gland, okay? The whole gland to be removed, and of course, we may sabotage the facial nerve, but with doing simple, you can see as this is a tumor from the deep lobe of the, and it is pleomorphic adenoma, leaving even a small piece of the pleomorphic adenoma to recur definitely. If we can see here, this is the parotid, and this is the main parotid, and this is the lesion which is coming from the deeper part of the parotid. So what we have done is, after exposing the lesion, small osteotomy here, displacing the mandible up, okay? Removal of the tumor, the whole tumor is there, These are the structures which are all are just sensory nerves, and the patient is finished with a very acceptable and no ugly clefts. This is the patient before, and this is the patient after. You can see the pharynx is completely open. Anyway, so this is just a simple way to explain what osteotomy can help. Anyway, thank you very much. Thank you.
I'm from British Columbia, Canada. I'm a professor of medicine at the University of British Columbia. I trained in clinical endocrinology and genetics, and I have a particular interest in technology. So the purpose of this talk is to go over some of the technologies to implement and guidelines to implement in your clinical practice to convert or upgrade your clinical practice from traditional care models to longevity models.
So why do we want to upgrade our clinical practice from traditional models to longevity models? Because there's a problem with our traditional healthcare systems. As you see, there's increasing proportion of chronic disease, aging society, and consumers, clients, and patients today want a change. They want longevity and wellness-related services to be implemented in their care plan.
It's also a very thriving field. There's a lot of interesting health tech solutions for us as physicians and healthcare providers to implement to meet consumer demand. It is an impressive field. It's a $9 trillion industry by 2028. This includes the supplements, the regenerative medicine, the technology, the clinics, the hospitals, the gyms. All of these different products and sectors are thinking of ways of bringing healthcare and wellness-related services to the end user. Now, what is a healthy longevity clinic? Now, a healthy longevity clinic is different than a traditional clinic through several ways. It promotes health, wellness, longevity, and disease prevention. It could be for anybody, independent of their pre-morbid state. It could be a healthy person that wants to understand their risks. It enhances health span, which is the period of life lived in good health. Now, longevity is a nice buzzword, but what really a longevity clinic does is that it focuses on identifying risks through very advanced biomarkers, in leveraging artificial intelligence, multi-omic technologies, and in providing therapies for the hope of living a healthy life independent of the longevity factor. It also enables early intervention in age-related diseases, and I'll give you an example. When you get diabetes, you go see an endocrinologist, but diabetes starts about 10 years before its diagnostic threshold. Wouldn't you want to know your risk 10 years earlier so you could introduce lifestyle and other changes? And that's what a longevity clinic has the ability to do, is to identify risks in a wellness state before the onset of disease. Years before the onset of disease, and that includes advanced biomarkers like genomics, epigenomics, biological age, and so on. It also optimizes health span by effectively targeting aging processes across the lifespan. So going back to the case of diabetes, when in traditional healthcare models, when you see a client with diabetes, you give them anti-diabetes medications and you suggest lifestyle changes. In a longevity clinic, you meet 5 or 6 different providers that will address the diabetes as a holistic disease. And they will, in the clinic, they will introduce lifestyle changes, movement pillars, beauty services, targeted therapies, and so on to ensure that the client's disease is being approached from a multi-system holistic manner. Now, we're fortunate in the UAE to have introduced the first healthy longevity medicine clinical guidelines by the Abu Dhabi Department of Health. And I encourage you to refer to these guidelines because they're quite comprehensive and they outline the necessary steps needed to upgrade your practice into a longevity practice and to seek the necessary clinical and regulatory licensing to launch a longevity medicine clinic. So what is needed to convert or upgrade or introduce a longevity medicine practice? Well, from a licensing perspective, the facility has to provide and adhere to local laws and standards and regulations, which Abu Dhabi has defined, and to be AAMEN certified for ADHICS and fully integrated with the Unified Electronic Medical Record System, MALAFI, and it has to be accredited by the international accreditation within 3 years of standard publication. In terms of staffing, typically a longevity clinic has to have a multidisciplinary healthcare provider, including physicians that are particularly trained on lifestyle medicine, regenerative medicine, longevity medicine. So these are typically family doctors, internal medicine specialists that have extra training in these subspecialties, nutritionists and clinical dietitians, physiotherapists and exercise physiologists, pharmacists, psychologists, and health coaches. As you can imagine, this is a multidisciplinary and costly initiative, but from the client and patient perspective, they receive a very comprehensive, multidisciplinary service. What about designing a longevity clinic? How is it different than traditional clinics? Well, it has to be approved by the Department of Health. You have to have approved medical devices, including exercise physiology testing, VO2 max testing, blood pressure monitors, various equipment for different biometrics, vision and hearing tools, ambulatory devices for monitors, and some clinics go on and on and on with various products, including MRIs, CT scans, CT coronary calcium scores, and so on. So you can introduce a basic longevity clinic or a very advanced longevity clinic. And in terms of cost and numbers, so CapEx, a typical cost for launching a comprehensive longevity clinic can vary between $5 million to $20 million because you need a lot of equipment in a very large space, anywhere from 20 to 40,000 square feet, and introduce all of these services. So Pure Health in Abu Dhabi has introduced a beautiful longevity clinic at Sheikh Shakood Medical Center. There are other clinics, international clinics from the United States that are coming to Dubai to establish these very elegant and large and multidisciplinary clinics. But anyone can convert their practice into a basic longevity clinic as long as they adhere by some of these guiding principles. Now, what about protocols? After you've built the asset and introduced all of these interesting products and staffing, well, you have to adopt an evidence-based standard treatment guidelines with evidence of monitoring implementation, which the document, the clinical practice document has outlined. It has to be and introduce tailored interventions, biomarker-focused, with AI-powered technology, including a multi-omics analytic platform, and provide continuous monitoring. So a typical client journey in a longevity clinic would include an initial assessment through a multidisciplinary approach, 100 gigabyte of data analysis from whole genome, epigenome, advanced blood work, full body imaging, and then putting all the 100 gigabyte of data into an analytic platform to identify risks in a predictive nature, and then to reassess risk quarterly over a 12-month period. During this 12-month period, the individual would work with a multidisciplinary team to identify and reverse risk factors. That's one of the goals of a longevity clinic. And then to introduce geoscience-related interventions, including supplements, regenerative therapies, hormone replacement therapies, peptides, and so on, to lower their risk and enhance their profile so they can live a longer, healthier life. So what would an initial evaluation look like on day one of a longevity clinic? Well, it will provide a comprehensive medical history, psychosocial health assessments, neurological health tests, including cognitive tests, mood assessments, sleep assessments, lifestyle assessments, validated risk prediction questionnaires, vital signs, physical exams, full body imaging, and so on. Typically, it ranges from 4 to 8 hours of assessments. And they typically provide lunch breaks and intermissions and educations. They could spread the evaluation between 2 days or several days, depending on the ability of the clinic. What about biomarkers, and how is that different than a traditional clinic model? Well, a comprehensive longevity clinic typically acquires 100 gigabytes of human data from various samples, including cardiovascular testing, VO2 max, echocardiogram, thyroid ultrasound, full body MRI, CT coronary calcium score, DEXA scan, advanced cardiovascular imaging, guideline-based cancer screening. Some offer cell-free DNA testing from blood, sleep assessments through FDA-approved wearable devices, wearable data integration through Oura Ring, Whoop, and so on. Metabolic function assessment, genetic, microbiome, epigenetic, biological age. The reason for doing all of this, again, is to identify risk pre-symptomatically and then to input all of the data into an analytic platform that will make sense of all this data from a predictive analytic tool. As you can imagine, this is very costly, very comprehensive. It may lead to incidental finding, unnecessary sequential testing, and potentially harm through biopsy or various interventions. But there's a general consensus amongst longevity experts in clinics that it's important to identify the risk of disease early through such a comprehensive assessment. What about treatments? What works today to help us live a longer, healthier life? The Abu Dhabi Department of Health guidelines have indicated what's applicable in green, what's in orange, what requires more research, and in red, what's currently not applicable. So a typical intervention that we provide in a longevity clinic that's acceptable include nutrition, exercise, sleep, mindfulness, meditation, breathing practices, avoiding toxins, education, and some supplements. Some clinics offer regenerative therapies, including for sports injuries and orthopedic procedures. And some are very experimental, like using rapamycin, using IV stem cells, and so on. And it's very important to choose an analytic platform that will understand and assess all of the data. And this afternoon we're having a longevity workshop where I'm going to dig deeper into this particular analytic platform that any clinic can implement as a turnkey model. And any clinic today with a budget of $30,000 to $50,000 can introduce these portable tests to acquire and analyze data and convert your practice into a basic longevity practice so you can identify a disease early and use AI tools for predictions. And these include pulmonary function tests, VO2 max testing, body scans, SPIC report for cardiac monitoring, Oura rings, and a mirror that can do a face scan for health assessments. Thanks a lot for your time. I hope you will consider adding longevity-related products and services. And by show of hands, who wants to live long to 120 years? Anybody? Right. Now, who wants to live healthy, independent of the length of time? Healthy. Good. So the objective is not longevity. The objective is living healthy longer, which is called health span. So a longevity clinic should focus on health span. Thank you.
Thank you, Doctor, for finishing before the time also. Thank you, everybody. I think we are rushing. We are limited with 2-3 minutes. During this time, unfortunately, we don't have time for question and answer. We have to نقدم certificate. وين نصور؟ احنا اهم شيء جاي مع certificate. Where is the
right side. Go to the right side. Fawaz. Sit there. Come other side. That's the volunteer.
Thank you very much for listening.